Hello, everyone. My name is Bruce Herman. I'm at the Department of Neurology at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin, and I'm happy to participate in this EpiPort clinical research curriculum, 13th module. And my topic is neurobehavioral comorbidities in children and adults with epilepsy. And this is an ever-increasing area of epilepsy research and care, and there are many opportunities to become involved in both clinical care and research in children and adults with epilepsy. So hopefully I'll give you a solid introduction and some useful clinical and research ideas for you going forward. Now, in terms of learning objectives, here's what I want to accomplish during this presentation. First, help you understand the prevalence of cognitive and behavioral comorbidities in children and adults in some relevant clinical presentations. Second, understand issues related to the timing of these comorbidities and give you a useful model. Third, introduce you to issues related to the course of these problems over time in both youth and adults with epilepsy. And fourth, identify the long-term consequences of these comorbidities on important life outcomes, such as education, work, peer, and family relationships. And then finally, we'll spend a little bit of time, and I won't say too much about it, but I have at the end of the presentation some slides identifying screening tools that can be utilized to address neurobehavioral comorbidities. Some of these are short and quick and useful in clinical settings. I have some information regarding more traditional measures that could be used in clinical research. So comorbidities fits in perfectly with the new definition of epilepsy published by Professor Fisher in 2014. Epilepsy is the sort of the brain generated by an enduring predisposition to generate seizures and by neurobiological, cognitive, psychological, and social consequences of this condition. And neurobehavioral comorbidities is sort of a catch-all phrase to refer to the collective cognitive, behavioral, and social complications associated with the epilepsies, which represent a major source of disability for youth and adults with epilepsy. Now, this is a relatively complex field, and in addition to, we're focusing on issues such as timing and course and long-term outcomes and so on, but more generally, this graphic gives you sort of a broader sense of some of the issues involved. At the center are the neurobehavioral comorbidities themselves, the cognitive, psychiatric, and social, and they can be influenced by a variety of conditions. Their timing, their presence, or course can be affected by underlying brain disorders, which are evident in some individuals with epilepsy, the epilepsy syndromes, which is a major area of inquiry, how these problems may or may not be related to specific epilepsy syndromes, brain development and aging processes, how the developing brain or the aging brain may affect the expression and course of these complications, and of course, core epilepsy characteristics, seizure frequency, medications, complications of the epilepsy such as status epilepticus, and so on. And furthermore, in gray within the circle, there are genotypic, psychological, and sociocultural influences that can affect these comorbidities as well. So it's a fairly complicated process. There's a nice review article by Lin et al. 2014, which is listed in the references, which might be helpful reading as well. And I will say that one paper to really take a look at if you're interested in the comorbidities is this review by Seizure and colleagues. It appeared in 2016 in Lancet Neurology. It says 2018 at the bottom, but that's not right. 2016 is the article by Seizure. And, comorbidities refers to two or more conditions occurring together at a given point. And the comorbidity pathways or the causal mechanisms can be of different sorts. And in this paper, Seizure et al. Reviewed the 5 pathways or causal mechanisms that can be involved in comorbidities and their expression and causal pathways. And I will point out that in my career, early on, the classic model was the third one, the resultant mechanisms, and that was that the person was living their life doing well until the occurrence of epilepsy, and then with the subsequent development of seizures, treatment, psychosocial complications that might be associated with epilepsy, then comorbidities developed, cognitive problems, psychological problems, social issues, and so on, and which may worsen over time as well. So it was indirect causal associations, epilepsy leading to seizures and treatment, which led to the comorbidities, which in many cases were viewed as progressive. Well, that mechanism has been changed. Those views are much more diverse now, and you'll get a sense of that as we go through this presentation, but that's a very helpful paper. And one more point of introduction, when we're talking about the neurobehavioral comorbidities, we talk about cognitive problems, we're actually referring to a collection of possible complications. These could be difficulties in specific cognitive domains, such as memory, aspects of language, executive function, psychomotor slowing. Similarly, when we're talking about psychiatric disorders, this could refer to a myriad of issues: depressive disorders, anxiety disorders, ADHD, schizophreniform psychoses. And in social complications, a wide net again, but would include employment and social relationships and social competence and the ability to interact and get along with others. So, getting into the cognitive comorbidities, and again, we're going to talk about prevalence to begin. Based on epidemiological evidence, there's an increased prevalence of cognitive problems in children with epilepsy, including those with uncomplicated epilepsies, compared to children without epilepsy. And I have a table I'll show you in just a second that documents that. In adults with epilepsy, there is far, far less epidemiological research. It's actually a wealth of evidence in the pediatric population, much rarer in the adult population. But in the adult literature, there are a number of clinical studies demonstrating increased cognitive problems among individuals with new onset and chronic epilepsy. So this slide shows epidemiological, based on population or community-based studies, published from 1985 through 2017. And listed here are 13 studies. And across these studies, there's a tremendous diversity, and again, they're measuring cognition. There's tremendous diversity in what was actually measured. Some studies only assessed IQ, some studies only assessed executive function, some studies looked at academic achievement, school performance, and some administered comprehensive neuropsychological batteries. So a lot of variability in how cognition was assessed, and a lot of variability in terms of who was studied. Syndromes and populations and so on. So little summaries of the primary findings of these studies are listed there. And the one thing that I'll point out is on the right is that in every study, there were more cognitive academic problems evident in children with epilepsy compared to control populations. This should come as no surprise. I mean, cognition is mediated by the brain. If you have a brain disorder, it's going to affect cognition in some way in many individuals. So from a population or an epidemiological standpoint, these problems are routinely detected. And now what I'll do is I'll show you one epidemiological investigation and two clinical studies just to make the point. So this paper by Russ and colleagues is especially notable. This is it came from the 2007 National Survey of Children's Health, in which they surveyed a little over 91,000 children from birth to age 17. They got quite a bit of information shown on the lower right: lifetime epilepsy information, details about mental health and mental health development, functional health indicators, service use, and access indicators. And in the blue box, you can see the relative risk of various outcomes that was detected in children with epilepsy. So the relative risk, for example, of limited activity was 9.22. The relative risk of grade repetition was 2.59. School problems was 1.63. Problems with social competency, interpersonal relationships, 2.16. And parent aggravation, 2.46. So this is, they did not assess cognition per se, but assess cognition-related activities such as academic performance. So clearly, in this population-based investigation, you have relatively precise relative risk of these various issues. Now, turning to the clinic, two studies. The first one, it comes from the UK, the Cormac studies, published in 2007 in Epilepsia, and they looked at the development of intellectual abilities in pediatric temporal lobe epilepsy. So they investigated 70 children with unilateral temporal lobe epilepsy, and they were presenting for surgical consideration. So they have more severe epilepsy, difficult to control, presenting to a tertiary care center for surgical consideration. Mean age was 11.7. And in the graphic on the right, you can see the curve, which is the normal distribution of intelligence. And in the black bars are the distribution of intellectual ability for the children that they study. You can see that the mean is shifted to the left, downward, lower IQ scores. And IQ was under 80 in 57% of the children, a significant subgroup. And when they were looking at predictors of lower IQ, the strongest predictor was an earlier age of onset of epilepsy, and that's actually a predictor variable that's been identified and reported numerous times throughout the neuropsychological literature. And the other interesting point is that although they had temporal lobe epilepsy, neuropsychological deficits were evident in areas other than memory. So it's not just a memory effect in the children with epilepsy, and again, this has been reported as well. But close investigation, more severely affected children with epilepsy, more severely affected cognition. Now, if we move to one of the so-called benign epilepsies, Professor Kaplan and colleagues at UCLA have long been interested in childhood absence epilepsy. Again, classically, this has been viewed as a relatively benign condition in terms of seizure control and outcome, but as it turns out, it can be very problematic in terms of the neurobehavioral comorbidities, and this is a very nice demonstration of that point. So they they studied 69 children with childhood onset epilepsy. Mean age was 9.6. Compared them to 103 age and gender matched controls, nicely matched 9.9. And they carried out a comprehensive evaluation including cognitive and linguistic testing as well as psychiatric assessment. Very nice combination of assessment modalities. And what they found was very striking. 25% of the sample of the children with absence epilepsy had subtle cognitive defects versus 6% in healthy controls. Very interestingly, 43% had linguistic abnormalities versus 15% of the healthy controls, and 61% had a formal psychiatric diagnosis versus 15% of the healthy controls. So very eye-opening that this benign, heretofore considered benign epilepsy had significant neurobehavioral comorbidities associated with it. So the opportunities for research in syndromes you would not think would reveal much in the way of comorbidities is certainly open. A lot of the research to date has taken place at tertiary care centers studying the more affected population, but there are many opportunities for this research more generally. Now, in the adult population, again, we have little epidemiological information regarding neuropsychological status. So I'll show you one large-scale study. This comes from Professors Helmstetter and Witt at the University of Bonn, where they have a very large sample of individuals with temporal lobe epilepsy. Again, this is a tertiary care center, so likely seeing the more severely affected individuals. And they carried out a nice assessment of higher cognitive function. You can see the domains listed at the left of that slide: verbal memory, figural memory, attention, language, motor function, visual construction, and a marker of IQ. Sample size is quite big, 600 patients and more. And for those individuals who had left temporal lobe epilepsy and right temporal lobe epilepsy, the proportion of people with abnormalities in those domains can be noted. So in the left TLE group, you can see that the most commonly detected abnormality occurred in verbal memory, which would be to be expected. In the right temporal lobe group, the cognitive domain that was most affected was figural memory, 59%. But notable is that significant proportions of abnormalities were found in other cognitive domains as well, consistent with the pediatric study, the Cormack et al. Study that I showed you before. So memory problems can be evident, but abnormalities can be evident in other cognitive domains as well. And the question is, why is that? What are the underlying neurobiological mechanisms, and what can be done about those issues? So, in summary, to this point, it's clear that epidemiological evidence supports this issue of concern regarding cognition, particularly in the pediatric population. This is reflected in clinical studies, and later on we'll deal with issues of timing and progression. Right now we'll move on to the issue of psychiatric comorbidities. So pediatric and adult epidemiological investigations have similarly revealed increased prevalence of mood disorders, anxiety disorders, attention deficit hyperactivity disorders, suicide, and other psychiatric disorders among individuals with epilepsy. Again, I'll show you some examples of this. And adults with epilepsy and psychiatric disorders have been shown to have more cognitive complaints, reduced role functioning, and greater stigma compared to adults without epilepsy. So here's a summary of pediatric psychiatric epidemiological studies from population-based and community-based investigations. And there are 17 studies. They're shown here through 2017. The first came as a famous investigation, the Isle of Wight study by Michael Rutter and colleagues, and 17 studies. And as in the cognition summary table, the methodology varies across these investigations. Some formally assess psychiatric comorbidity through structured interviews. Some have parents complete rating scales, behavioral scales regarding the children. Some use teachers, some use multiple informants. And the sample sizes vary considerably across the studies. But again, as in the cognitive summary table, every investigation here has documented in some fashion higher rates of psychiatric behavioral comorbidities in children with epilepsy compared to controls. And you can see the small details in the text under primary findings. And as before, what we'll do is we'll turn to a couple examples of this, and there's one that's particularly striking. And this comes from Davies and colleagues from the UK, and they used data from the 1999 British Child and Adolescent Mental Health Survey. This included over 10,000 children, ages 5 to 15. The information derived came from structured interviews, teacher and clinician ratings, and they found 67 individuals or children with epilepsy, 42 of whom had uncomplicated epilepsies and 25 complicated epilepsies. And in addition to reporting their findings, they compared their results to the very first study, the Isle of Wight study by Michael Rutter. And so they used some similar procedures and methods to allow that comparison. Furthermore, they were able to compare the children with epilepsy, both complicated and uncomplicated, to the general population and children who had other medical comorbidities to see if there was anything unique to epilepsy. And here's what they found. So in green is the Rutter study from 1970. The Davies study is in blue from 2003. And at the right, you see the rates of psychiatric comorbidity, the percent in those who had uncomplicated and complicated epilepsy, much higher in those with complicated epilepsy. And the rates of both groups of children with epilepsy was elevated compared to those with general medical conditions in the general population. So you see a stair-step sort of effect of uncomplicated epilepsy and then complicated epilepsy. And the other thing that's so striking is despite a 33-year interval between these two studies, the rates of abnormalities or of problems were very comparable between the two studies. It really is a very remarkable comparison. A little bit disappointing to see that there was not a major improvement over that 30-year period. And if we go back to or return to our the previous investigation I mentioned by Russ and colleagues, in that population-based investigation, they looked at rates of psychiatric comorbidities, including depression, anxiety, ADHD, conduct disorders, developmental delay, and autism spectrum disorder. And you can see the rates of those diagnoses compared to a control population. So again, from a population-based perspective, increased risk of a variety of conditions, more so compared to other medical conditions and, of course, controls. And transitioning to social comorbidities in a briefer summary here, in a population-based study conducted by the CDC, people with epilepsy were found to have higher rates of unemployment, lower income, and lower educational attainment. The 2010 National Health Interview indicated that adults with active epilepsy had significantly more difficulty participating in activities compared to adults without epilepsy, including leisure or social activities, going out with friends or family, and transportation issues. So difficult situations to be sure. And a final summary, the USA National Survey of Children's Health reported that children with epilepsy had lower social competence, that is, the ability to have productive and satisfying relationships, as well as more physical and functional disabilities compared to children without epilepsy. So we'll take a brief break, and then we will turn to issues of timing and course of these comorbidities. Now we're going to turn to issues related to the timing and course of the comorbidities. And by way of summary, and then I'll show you the details as we move forward, neurobehavioral comorbidities are present early in the course of epilepsy. They don't tend to disappear over time. And there are limited diagnostic and therapeutic guidelines for development interventions, and we'll go through these points as we move forward. So here's a schematic that I think we found to be useful. We've used this in our thinking in our publications. And in the pediatric population, if it becomes useful to start at the beginning, because there are so many factors can affect behavior and cognition, it's hard to sort them out. But if you start at the beginning, early in the course of epilepsy, prior to years of recurring seizures and possibly even prior to AED initiation, you can get a close look at the status of cognition and behavior, which you can then monitor going forward and look at the long-term outcomes. And again, as I mentioned at the outset, the common view, classic view, was that there were fewer problems at this point in time, and they largely developed in a rolling manner over time, getting bigger and more problematic as the course of epilepsy went on. However, that's sort of turned on its ear through a variety of research projects. And one of a very important one in this matter came from the Dutch study group of epilepsy in childhood, Hoostrom and colleagues. And in this study, which was really quite remarkable, they had 51 children with newly diagnosed uncomplicated epilepsy. And what did they mean by uncomplicated? They meant no known lesion or cause identified. The children were in mainstream education. They were receiving outpatient care only, and they had, quote, epilepsy only. This is a phrase which is used quite a bit in the literature now to distinguish it from more severe, intractable, and catastrophic epilepsies. And they had 48 matched controls who were classmates and friends. And remarkably, they tested the children with epilepsy within 48 hours of their diagnosis, so they were all drug naive. And they did a very thorough job of assessment. They assessed cognition, behavior, they did teacher and parent interviews, and did an audit of school career. And they found, and let me get you oriented to this slide, I can get my arrow here. This is the level of performance by the controls. So downgoing bars represent performance by the epilepsy children worse compared to the controls. Upgoing bars would be better performance. And on the y-axis are z-scores. And so what you can see is that problems are evident right at the very start. There are significantly more behavioral problems in the children with epilepsy. There are more problems with attention. They have slower reaction times. They have poor learning and a tendency to poor performance on academic skill tests. The other thing that they found through their audit of school performance, they looked specifically at who needed special school assistance in their regular classrooms. And this was needed by 51% of the epilepsy patients compared to 27% of the controls. And they concluded that school career is already at risk, even at this early state immediately after diagnosis. So the kids were struggling antecedent to their first recognized seizure and diagnosis. And this literature has developed relatively quickly. Before the Ostrom study, Professor Austin and colleagues at the University of Indiana had studied behavioral problems and were able to document the presence of behavioral problems at or prior to the diagnosis of epilepsy. Ostrom et al. Study moved into cognition, and several other studies have demonstrated similar points. Here is a summary slide of new onset epilepsy studies that looked at cognition. And these date from 1983, and I've carried these up through 2017. And again, a couple of points about this is there are many studies where the children were drug naive, so not complicated by the effects of administration of AEDs. These are all controlled studies that were compared directly to a control population. And again, there was variability in the context of the cognitive assessment. Some were very, very thorough. Some were more focused in their evaluation. This is a mix of different epilepsy syndromes and sample sizes. But in virtually every case, problems were identified, cognitive problems were identified in the children with epilepsy at the time of or shortly after the diagnosis of epilepsy. So these issues are present early on, which provides a window of opportunity for identification and intervention. And the other interesting point, again, this was pointed out by Ostrom, is that careful history about the child's behavior and functional status antecedent to the diagnosis gives some very interesting information. In Ostrom's case, there was a need for more school help for the children with epilepsy, and in that period of time, before recognized seizures, before the diagnosis, this is a period of time where there are no frank seizures, medications, or social or personal reactions to having seizures. So it's a very interesting time period to investigate. And there have been several reports of detectable issues antecedent to epilepsy onset. As I mentioned, Professor Austin and Dunn and colleagues in Indiana reported behavioral adjustment issues prior to the diagnosis of epilepsy. Antecedent histories of ADHD have been reported, academic problems of the exact type reported by the Dutch, elevated lifetime to date rates of depression, anxiety, and even provision of special services such as speech therapy. So these problems have been called essential comorbidities by Ann Berg. The etiology of these issues remains to be determined, but it infers the presence of an abnormal pre-existing substrate or family aggregation of comorbidities or other issues. Now, turning again to adults, we have less information. This comes from a review by Professors Witt and Helmstetter. It was published in 2015. And they summarized cognition in new onset untreated adult epilepsy. And there were 11 studies that had been published from 1992 to 2014. Sample size varied from 16 to 257. Again, variability in the range of cognitive domains assessed and their comprehensiveness, and variability in the definitions of abnormality. But again, as in the pediatric literature, increased cognitive impairment in the individuals with epilepsy was detected in all the investigations. So the important point being, from the get-go, there are issues to be addressed, and there just needs, what those issues are, and need to be clarified. Here's one example of a new onset study. This comes from Liverpool, Taylor and colleagues. And they investigated 155 patients with epilepsy before the start of AED treatment, compared them to 87 healthy controls. Again, our performance by the controls is here, so performances lower than this point represent poor performance. Performances above the bar represent better performances. And the trend, as you can see, is across these various cognitive domains, poor performance at the start of treatment, even before the initiation of AED. And this was seen in a variety of cognitive domains, including measures of psychomotor speed. And psychomotor speed is often related to AED effects, but here there are no AEDs administered, so the psychomotor slowing is indigenous to the onset of the epilepsy. Multiple aspects of memory and aspects of language and executive function. Nice example of the new onset effect in adults. Now, the other thing to consider is, as everyone knows, is that the world population is getting older. And one of the major epidemiological bumps for epilepsy is in the aging and elderly population. So this is going to be a big wave for the future. Extremely little has been known about the status of cognition in elders with new onset epilepsy. So Witt and colleagues in Bonn obtained a cohort of 257 untreated new onset epilepsy patients from 16 to 95. And they administered a measure of executive function called EpiTrack, and I'll show you this later on. It's short, quick, and gives you a quick assessment of a particular cognitive domain. They also assess subjective cognitive function and quality of life. And what they found was that 58% of the patients demonstrated deficits in executive function. So they were only looking at this one domain. 58% showed deficits there. It didn't look at other domains such as memory, speech and language, and so on. And the major determinants of this cognitive abnormality in the adults were antecedent presence of cerebrovascular diseases and etiology, neurological comorbidities, and higher body mass index. So I think the aging issues will be especially prominent in our field going forward as they are in other fields. Now we're going to move on to behavioral and psychiatric status. We've talked a lot about cognition and cognitive issues. What does it look like in terms of new onset cases in behavioral status? Again, here's a summary slide. And we have 12 represented studies here. First goes back to 1984, Peter Hoare, followed by Joan Austin and her group, and David Dunn. And most of these studies have controls. This goes dates to 1984 up to 2019. There's last paper was published in January. Most but not all of these studies use controls. And again, there was variability in terms of what was assessed, how it was assessed, but they were all assessing aspects of behavioral adjustment, depression, anxiety, and other features. And in every case, at new onset cases, problems were evident at the very get-go of the disorder. Again, a bit of a surprise compared to the classic views. This comes from our own group. Janet Jones conducts very careful, structured psychiatric interviews of the children with new onset epilepsy and also separately with the parents. And here you see the rates of various psychiatric comorbidities. We've talked about academic problems. If we focus on ADHD, anxiety, and depression, you you can see that lifetime-to-date rates are elevated in the children with epilepsy compared to controls for those three psychiatric disorders. And here, this again comes from our sample. This involves 125 children with new onset epilepsy and 80 healthy controls. Of the epilepsy patients, 64 have localization-related epilepsies and 61 have generalized epilepsies. And if we look at the top two graphs here, get my arrow, total problems and total competence. So total behavioral problems, high scores are bad, so the higher the scores, the more problems. You can see that the localization-related, focal, and the generalized epilepsy cases both show higher rates compared to the controls, no differences between these two groups. And then down below we have internalizing problems, anxiety, depression, externalizing problems, and other problems such as attention. The same trends are evident. If we look at total competence, high scores are good, low scores represent more problems. And here we see that both the focal and the generalized groups have lower scores compared to the controls. And when you break competence down into its component parts, school competence, social competence, those are lower in the groups as well. So decreased competence, total, social, school, and increased behavioral problems were seen at onset in the children with epilepsy versus controls. And we didn't see any major differences between the broad syndrome groupings. The interesting thing about this is we did look, and as reported by Kevin Dabbs, is we also collect morphometric information, MRIs, and we do quantitative processing. We looked at the relationship, is there any relationship between the parents' reports of competence and behavioral problems and detectable relationships in the children's brains. And we did find relationships, which I think is interesting. So we found increasing better competence scores associated with increasing cortical thickness, especially in frontal regions. And you can see these relationships for total competence in its component scales. And in relation to behavior problems, increasing or worse behavioral scores were associated with decreased cortical thickness, especially for externalizing or acting out behavioral issues, and especially in frontal areas. You can see it in total problems, and then for some of these specific scales. So the parents' reports on these scales can be related to detectable relationships in the child's brain. Now, what about in the adult population? Again, a little bit less information. I have 3 studies listed here for you. Zhu et al. In 2017 studied 259 adults and found that 33% of the new onset adults with epilepsy exhibited increased psychological distress. Lane et al. In 2018 looked at 105 new onset cases, found increased depression in the individuals with new onset epilepsies. And Lee et al. In 2018 looked at 141 adults with recent onset epilepsy, increased rates of anxiety and depression in those groups. So similar to the children, although with less information, arguably less information, the same trends are evident. Now, the question then is, okay, at onset and even before onset, neurobehavioral comorbidities can be detected. What is it that happens over time? And by getting a baseline on individuals with epilepsy close in time to the diagnosis, that provides a very useful baseline with which to then follow them over time. Now, we're focusing here on children, but again, you can do this with adults. If you pick up an adult with new onset epilepsy, you could follow them over time to see what the course is going forward. And I'll turn first to some data from our group. We looked at cognitive developments. Now, what you see here are raw IQ scores. These are not IQ scores themselves. These are the raw score points. So an IQ test is composed of specific subtests. Each subtest has a raw score, and if you add those up, you can get a total raw score. And if you use that, you can, as kids get older, they get smarter and they pick up more points over time, so you can monitor their intellectual development, so to speak, with the raw scores. So we see the kids, as I mentioned, at baseline, and then 2 years later after baseline, and then 5 years after baseline. And these are the plots that we see for the children with epilepsy and the controls. So first of all, high scores are good. At the outset, there's an offset shown by the children with epilepsy, and that offset is maintained 2 years later and 5 years later without any worsening or improvement. It's a static difference that's basically demonstrated by parallel lines out to 5 years without progression. The same thing can be seen if we look at a different cognitive ability, and that's executive function. This is a measure of executive function. It's a sorting task. And again, the same trend is evident. High scores are good. We see an offset at baseline, significant offset at baseline, and that offset is maintained at 2 years and 5 years later without progression. Now, can some children and individuals get worse over time? Certainly. These are mean trends. But what you can see is that there does not appear in these children who, like Ostrom et al., have uncomplicated epilepsies. They maintain their cognition, develop at a normal rate compared to the controls, but they're just offset compared to the controls over time. Now, if we look at academics, the same general trends are evident. So let's look here at word reading ability. So at the outset, we were able to identify children with epilepsy who were struggling, had some academic problems. They're shown in this blue bar. Red are children with epilepsy who did not have a history of academic problems and are healthy controls. Again, we see them at baseline, 2 years, 5 years. And you can see the children with epilepsy, in terms of their word reading ability, who had academic struggles, pretty much stay stable out to 5 years. There's no worsening over time. Same is true of these other groups. They really don't differ, and their performance is maintained over time. That's seen for spelling. In arithmetic, there might be a little bit of worsening out to 5 years in the kids who had some baseline abnormalities. But these weren't significant. The academic problems seen at baseline persisted over 2 and 5 year follow-ups without progression. There's no real difference between epilepsy syndrome and in our cohort. Now, I will point out that there is more variability in the findings in regard to academic achievement. There are different tests that can be used, and we used a relatively uncomplicated test, the wide range achievement test. The Indianapolis group has used a more sophisticated assessment of academic achievement, and they have reported and have documented some exacerbation of academic problems in the children with epilepsy. So it may depend to some degree on what measures you're using. So there's a bit more of a mixed literature in regards to academic achievement. In regards to psychiatric status, again, if we return to our diagnoses, again, this is provided by Dr. Jones. Here, if we look at ADHD diagnoses in the control and the epilepsy groups, anxiety in the control and epilepsy groups, and depression in the two groups, what you can see is that there's no worsening of no increased rate. In fact, they decrease a little bit, not significantly. They're not worsening over time. A little bit less depression here. Always higher in the patients with epilepsy, but not worsening over 2 years. We don't have, we're not showing you 5-year data here. So relatively stable course, and what you see when people come in is largely what you might see going forward. Now, this topic of progression and concern regarding the course of epilepsy has a very, very long history. It's a very long and interesting history. In fact, if I can point out, the very first study addressing the question of what happens to cognition over time was performed by Fox in 1924. This was an epilepsy colony in the UK. The most recent study in the pediatric population was in 2016. And in adults, the first empirical study was in 1934. Last was 2016. Now, what's important to note is that these are uncontrolled studies that did not have a control group. The main point is this concern goes back to 1924. Now let's look at controlled studies. And in controlled studies, They administered an objective measure of cognition. They had a control group with which they could compare people, and they followed them over some period of time. Sorry for the error here, it should be in pediatrics and adults. But the earliest study, controlled study, was in 1983. Most recent was 2016. In adults, the earliest study was 2004. Latest is 2017. There have not been that many studies, 11 in peds, 9 in adults, variable test-retest interval. And the thing that I think is somewhat interesting is that although there's been this interest, the total number of epilepsy subjects that has been investigated in these controlled studies is very modest. 676 children with epilepsy, 543 adults. There's a lot of concern. There have not been that many studies, and it's involved a modest number of epilepsy participants. And this is not cross-sectional, this is prospective, seeing a patient at baseline and then seeing them at some point going forward. There are a lot of cross-sectional investigations, but cross-sectional investigations do not provide the precise information that you get from prospective studies. There have been 3 major reviews of this literature. This is the most recent one. It's in Press, and the actual stories are pretty similar. And that is that dealing with a broader range of individuals with epilepsy, not the idiopathic self-limiting forms of epilepsy, but in the broader world of epilepsy, progressive and abnormal cognitive course occurs in a subset of patients. Estimates vary, but somewhere in the neighborhood perhaps of 25%. And those who have these abnormal cognitive courses tend to have more severe and complicated epilepsies, more complications such as status epilepticus. We did a 4-year investigation of this in chronic temporal lobe epilepsy. We had 100 temporal lobe epilepsy patients, 82 controls, found an abnormal course in the epilepsy patients in 25%. It was predictable by increasing chronological age, morphometric abnormalities at baseline, and so on. So the findings were relatively consistent with the general trends. But it seems to be a less frequently occurring issue, but it can be detected. And I refer you to this review article in particular, which should be published, should come out in the near future, and provides a summary of the literature to date. So then the question is what are the persisting effects of neurobehavioral comorbidities on life course? And if we talk about children for the moment, what is their life course going forward? And the thing about the pediatric literature, again, is that there is a very large, what I would consider to be a large literature, and rich literature, looking at the eventual adult outcomes of persons who had childhood onset epilepsies. And as you would expect, there are more problems in those who had childhood onset epilepsies compared to controls, and a variety of issues: employment, stable relationships, independent living, and so on. That's no surprise. What's a bit more of a surprise is that those who had idiopathic uncomplicated epilepsies tended to show the same general patterns. And there's been some variability in the degree to which clinical epilepsy variables would predict that outcome. There is some more recent evidence that has been looking at the presence of baseline neurobehavioral comorbidities and its effect on life course. Ann Berg, through the Connecticut epilepsy study, showed that those individuals with childhood onset epilepsy who had psychiatric comorbidities and academic problems early on tended to have much more problematic outcomes in young adulthood. We found the same thing in our cohort, that those who had ADHD and academic problems, when they came in for their initial evaluations, had a much more difficult course 10 years later. So I think there's modest evidence that these neurobehavioral comorbidities will impact on life course. It's not unexpected given what's known in the general population, that those who have ADHD or learning disabilities and so on can have a more difficult course over life compared to those who don't have those diagnoses. But the evidence thus far is modest, pointing in the right direction, and the evidence is somewhat limited to date. So, how to address these comorbidities? Well, it's clear that cognitive problems are a major source of impairment that are evident at the time of diagnosis, and so screening of cognition and academic performance is certainly indicated. I don't think anybody would argue with that. And due to the greater prevalence of psychiatric disorders in children and adults with epilepsy, routine screening should be a standard component of epilepsy care. Addressing these cognitive and psychiatric problems will likely improve social outcomes. So let me just summarize to this point. So regarding the prevalence of these disorders, there's significantly elevated neurobehavioral comorbidity versus population controls. Regarding the timing, these can be observed at or prior to the diagnosis. The course, they can be largely stable for a lion's share of people with progressive difficulties in a discernible minority. Regarding the likely consequences of these neurobehavioral comorbidities on life outcomes, they appear to have some impact on life outcomes in young adults, but much remains to be learned about this going forward. And we'll turn now to the issue of some screening tools to utilize to address neurobehavioral comorbidities in order to know who, when, and how to refer appropriately. And a few website resources here. These are publicly available screening instruments for children and adults. These can be used in the clinic. They're publicly available. You don't have to purchase them. And they could be used for research purposes as well. So there are other potential resources for screening. I just want to mention a few of these and point out some resources, and you can pursue these accordingly. This is put together by Janet Jones, and this shows rating scales for behavioral comorbidities, anxiety, depression. And this is a very helpful slide because you can see the rating scales. Let me just get my arrow. Here are the various rating scales that are available, the appropriate age range for that measure, the number of items are all relatively reasonable in terms of the number of items that are involved, who they're completed by, the patient, the parent, teachers, and time to complete. So these are all relatively quick and efficient and user-friendly. On the adult side, most people probably know about this, but there's the Neurological Disorders Depression Inventory for Epilepsy, the so-called NIDDI, is a very quick screener to detect major depression. Depression is common, it's underdetected, it's undertreated, it can be a lethal disease. It's very important to detect this. And this is a very brief 6-item scale that shows very nice psychometrics in terms of detectability of underlying major depression. This has been translated into a large number of languages. There's validity data in the various translations and so on. I think it's an easy clinical and research tool for those who are interested in this particular issue. There's been a downward extension of this by Professor Wagner and colleagues in South Carolina. Again, it is efficient in terms of the number of items that are administered, and it also has good psychometrics. From a more traditional assessment perspective, for those who are more interested in research grade or even traditional clinical measures, again, this is a slide from Dr. Jones that lists semi-structured interviews for psychiatric disorders, commonly used, many of these commonly used in the epilepsy literature, questionnaires for screening for psychiatric disorders. Some of these are relatively easy to administer, not complicated. questionnaires for specific psychiatric disorders, mood disorders, and anxiety disorders, semi-structured interviews for personality disorders, which arguably are understudied in epilepsy, and questionnaires for personality disorders. Cognitive screening, a very interesting issue. We've mentioned the EpiTrack a couple of times. This is developed by Professor Christoph Helmstedt at the University of Bonn. There's an EpiTrack Junior, and there's an EpiTrack for adults. Again, this emphasizes assessment of executive function. Normed on 277 individuals from 6 to 18. That's the applicable age range. And it assesses a number of specific abilities that would fall within the domain of executive function. There is an adult version, normed on 689 individuals from 16 to 84 years. Again, similar tasks, adult appropriate. That can be administered quickly and efficiently. And it's a useful screen. Again, it's primarily for executive function. And if they're positive, this is a test where it can be given. If it's abnormal, then a referral for a more traditional neuropsychological evaluation. And lastly, just a few review articles. A few are listed here that cover specific topics of neurobehavioral comorbidities, and several pages of references that have been mentioned in this presentation and others. So thank you for your attention. If anyone has questions, should feel free to contact me. I'd be happy to answer what I can and pass the questions on to colleagues who are who know more about your question than I do. And I hope this has been helpful to you. And I think getting you involved in the neurobehavioral comorbidities is quite important. It will improve care and improve the quality of life of individuals affected by epilepsy. Thank you.